I'd like to describe the surgical technique for medial ligament repair with suture tape augmentation. 4 swivel locks are required, which are preloaded with fibre tape as illustrated. The skin is then marked using a skin marker, the joint line established, medial epicondyle, and distally a point between the pes and joint line roughly halfway between, as illustrated here. Through a stab incision or through an open exposure, the medial epicondyle is identified, and crucially, the drill point is just proximal and posterior to this. The tap is then inserted carefully as a drill guide is removed and tapped fully until the laser line to ensure full insertion of the 4.5 swivel lock. This is inserted with the fibre tape preloaded and advanced until flush with the cortex to minimise any risk of subcutaneous irritation and also to ensure optimal strength of the fixation itself. A hemostat is then passed subcutaneously to the pre-marked insertion site. The suture, which has been removed from the swivel lock, is then used to shuttle the fibre tape effortlessly distally. The insertion point tends to be between the anterior third and posterior 2/3, and this can be more readily identified with an open exposure, but is being illustrated here, ensuring that even tension is evident throughout range. The distal swivel lock is then drilled for, but the fibre tape wrapped round to ensure a degree of isometricity, the joint's taken into full extension and comfortably into flexion. And if this is nice and balanced, then the procedure can be completed by tapping once again until flush with the laser line. The second swivel lock is then prepared. The eyelet is of adequate size to allow easy passage of the fibre tape, and without additional tension, this can be positioned at the tip of the tap and then marked at the laser line. This allows for the length of the anchor itself and prevents any additional tensioning of the construct during insertion. It also means that no additional tension need be applied to the construct, as excessive tension can be detrimental, effectively constraining and compressing the medial compartment. Once again, before securing, a full range of movement is tested. Here we can see we have a physiological give in 30 degrees of flexion, which should match the unaffected side with no tension in deep flexion. The construct is then completed. For a severely disrupted MCL, approximation of the soft tissue may well be essential, and this would be the approach that could be used. Here we're illustrating the percutaneous suture augmentation and now preparing to augment this with a posterior oblique support. The semimembranosus is identified distally and adductor tubercle proximally before this is drilled and subsequently tapped. Once again, a preloaded 4.75 is inserted and advanced until flush with the cortex. The posterior oblique is rather atypical in that it's only taught in full extension and will prevent hyperextension. And testing should bear this in mind, as it's often redundant in flexion. We're now securing the fibre tape distally, but measuring in full extension to take this into consideration. A slight purse string suture was also used to grab the soft tissues and pull it to the principal suture tape, and this has also been illustrated proximally, and this can rebalance the soft tissues to ensure that adequate tension is restored. A hitch stitch is used and the procedure complete.